May 11th. We're tuning in for what will probably be our last committee discussion for the session. So pretty exciting. And we have one of our most favorite people here as the last. Good way to whiteboard them. But we have Department of Financial Regulation with us to talk about some preliminary findings through a study they're doing with mental health parity. I'm going to turn it over to discussion.
So for the record, Sebastian Duango for the Department of Financial Regulation. And I'm really grateful to all of you for making some time for us this morning, because we're really excited to share with you some of the preliminary results that we've gotten from a mental health parity analysis that we are currently performing with some of the federal grant money that we received. And I'm joined this morning over Zoom by Anna Van Fleet, who is the Director of Rates and Forms for the department. And just by way of background, to explain a little bit of what we're trying to do here. Part of what we're using this grant money for is to really overhaul our rates and forms processes. That way we can catch more potential issues on the front end when the issuers file their rates and forms for approval with the department. And we're doing fewer things to enforce the law on the back end, for instance, when we receive a consumer complaint. So as you guys probably already know, 2 years ago, we received a substantial grant from CMS under the State Flexibility to Stabilize the Market grant program. And the grant program is basically intended to give states the resources to study their insurance markets and implement potential improvements. So we've done 3 grant projects so far. The first is the development of a new essential health benefits benchmark plan. That plan was approved in July of 2022, and it adds coverage for hearing loss and hearing aids, as well as removes benefit limits that are considered discriminatory under federal law. The second project is health insurance form and formulary review processes and verification tools, which sounds like a lot, but like I said, what we are doing is just really trying to overhaul our form review processes. That way we can catch things on the front end. And I think at this point, I'll ask Anna to jump on really quickly to just briefly explain what we do in the form review process.
Hi, thank you. Anna Van Fleet, Vermont Department of Financial Regulation. I'm the Director of Rates and Forms for life and health insurance. And to be clear, the rates that I review are not the rates that the Green Mountain Care reviews. We review other stuff. When we receive, and we have open currently, filings from MVP and Blue Cross to begin their review for next year's plan document. We review hundreds of pages of statements of benefits and coverages. Those are the shopping guides that go along with the plans. We also review the long form certificate. That's what details what's covered in the plan. And then the statement of benefits and coverages details how rich the coverage is. But for the most part, all of the plans on the exchange have to cover, not for the most part, completely, all of the plans have to cover state mandated benefits, essential health benefits, and we're checking for that. it's easier to find benefit coverages than it is to find all the details that would support, some of the mental health parity work that we're diving into here. It's really deep in the weeds. And so that's why we're having the consultant help us dig, in the right direction to get the most value out of the work. Is that good, Sebastian?
Thank you, Anna.
We have one question, Leslie.
This is 101. I'm a little confused about what you mean by form. Like, what's a form? I'm sorry. Like, who's filling that out?
Yeah, I will take a crack at answering that. And then Anna, if you could fill in any details that I missed. So for every plan year, insurers have to submit their forms for each plan to the department. And we call them forms, but they're basically an outline of what the specific coverage under that plan is. So if we're talking about Blue Cross Blue Shield of Vermont's standard silver plan that they are offering on the exchange, the form for that plan will outline all of the benefits that particular plan offers.
Okay, thank you. I picture form like something one fills out, so that's what I'm trying.
Yeah, it's an insurance contract.
Okay, that's helpful. Thank you.
So that's the form review process, and that's what we're working to overhaul in project number 2. And then our last project is the one I'm really excited about, which is medical nutrition therapy utilization review. One of the services we were interested in adding in our benchmark plan was nutrition services, and there just wasn't enough data on how those services are being used. So we've contracted with Barry Dunn, who is also so excited about this particular work that they are working with us at a reduced rate. We are looking at medical nutrition therapy and how it's being used in Vermont and what the barriers to access are. And I feel like we've got the dream team working on this project with us because we just have a lot of engagement from stakeholders outside of state government. And I'm just really, it's been nice to be on one of the calls for the MNT project and think, wow, I'm the least knowledgeable person on this call.
Party?
I'm really interested in wondering if there's something that you can send to the committee that would help us dig into it a little bit more ourselves.
Yeah.
Thank you.
Yeah, for sure. And I think that you're going to hear more about it next year, especially as you'll probably hear more about anti-obesity medications next year. And I think this project really plays into that as well.
Awesome. That's great. That's a scary thing.
So going back to our second project, we're looking at 2 things with respect to mental health parity. We want to look at the forms to see how compliant the issuers are with both the Mental Health Parity and Addiction Equity Act, or MHPAEA, and 8 VSA 4089 b, which is Vermont's mental health parity statute. The other project that we're doing with this is compiling a list of mental health and substance use disorder codes that are considered primary for the purposes of our mental health parity statute. And I'll show you how that works on the slide after next. Okay, so MHPAEA. So this is federal law, and it requires health plans that cover mental health benefits to offer the same level of benefits that they do for medical surgical care. So MHPAEA does not require plans to provide mental health benefits. What it says is that if a plan provides those benefits, they have to be at least as good as the medical and surgical benefits that are offered by the plan. And part of that is prohibiting plans from imposing non-quantitative treatment limitations on mental health benefits unless the process or standards used to impose those limitations are the same as the process and standards used to impose limitations on medical or surgical benefits. So when we're talking about non-quantitative treatment limitations, we're talking about things like prior auth, we're talking about concurrent review, things like provider accreditation standards, formulary design, and step therapy protocols. So just to give you an idea of what a non-quantitative treatment limitation works and how it applies in this context. Imagine that an insurer required prior authorization for non-emergency inpatient care. And they did that both for mental health and for medical and surgical. That would be totally fine under MHPAEA because they're using the same non-quantitative treatment limitation on both the mental health and the medical surgical side. But if that same insurer then dropped the prior auth requirement for inpatient non-emergency med-surg services, that non-quantitative treatment limitation on the mental health side would violate MHPAEA. So that's the kind of thing that we're looking for in our analysis. Does that make sense?
Can you go back to the previous slide?
Yeah.
Is there any way that PBMs are impacted by this? Or does it only deal with insurers? Yeah,
so this does impact PBMs indirectly. And what's nice about MHPAEA is that because it is federal law, it applies to all health plans. It applies to ERISA plans. It applies to limited benefit plans. It doesn't apply to Medicare, but that's only because Medicare has its own protections for mental health services. But this applies much more broadly than our mental health parity statute does, which is why we're pretty, we wanted to include this in our mental health parity analysis.
Great, thank you.
Okay, so what does Vermont require? So unlike the feds, we actually require insurers that fall under our jurisdiction to cover mental health and substance use disorder benefits. And we prohibit the establishment of any rate, term, or condition that places a greater burden on an insured for access to treatment for a mental health condition than for access to treatment for other health conditions. And specifically include no greater copays for primary mental health care services and no greater copays for specialty mental health care services. And so when we're talking about identifying the primary mental health care codes, it's for the purposes of figuring out which copays apply for this statute.
So Blue Cross, Blue Shield, the MVP, you've negotiated with them or going to that these requirements have to be covered?
No, there's no negotiation. They have to cover mental health benefits.
And this has been this is a statute that's been in place for.
Yes, this statute has been in place in one form or another since 1997.
I was wondering that, thank you.
Okay, thanks.
And if I could add, Sebastian, the list of codes that are established as primary mental health has also been established since 2013. And our process is on the department to revisit the list with stakeholders. So I think maybe we missed that there is an existing list and everybody's well in agreement and compliance with it. And so we're just revisiting it to see if it needs to be modernized, which is our duty to do every few years. Thanks.
Thank you.
Just a quick question. Are we ever going to get away from using the term mental health care?
That's the term that's in statute. But
I know it is. I'm just wondering, is there any kind of movement to because it seems to me we still have separated mental health and physical health.
Yep.
And I'm wondering if there's a way to.
Yeah. So that's a good question, and I'm the department's representative on the Mental Health Integration Council, which is led by the Department of Mental Health. And one of their big pushes is to say that mental health care is healthcare. There is no distinction between mental health care and med surg. It's all the same thing. So I think we are moving in that direction from a practical standpoint, even if the law still uses the term mental health care.
Okay, thank you.
So in our non-quantitative treatment limitation analysis, we're looking at the following 8 focus areas, which includes prior auth concurrent review, formulary design, benefit exclusions, medical policies, which is basically statements that every insurer drafts about a particular topic to state when they believe a certain service is medically necessary or not. Provider reimbursement, which I know many of you are excited about, or many of you want to talk about. So we're going to get there. Standards for provider accreditation and restrictions on billing codes.
All right, you have a question?
Yes, could you describe what concurrent review is?
Yeah, so sometimes you'll have a prior authorization that will be granted, and this happens a lot with prescription drugs. And the authorization will only be valid for 6 months, whereupon there will be what's called a concurrent review to make sure that that drug is still medically necessary.
Okay.
So you can think of concurrent review as basically midstream prior authorization, even though the drug or service has already been authorized.
Right. Yeah, I see. Yeah, thank you.
So we've requested NQTL analysis from all of our insurers, and because I do want to call out when things are being done the right way. Blue Cross Blue Shield of Vermont did provide the most complete analysis. So we're very happy with them. And we will request additional information from MVP and Cigna where necessary.
So can I ask, when you're doing this analysis, are you looking at just the policies they offer on the exchange, or are you looking at their self-insured policies?
Yeah, we are looking at, Anna, correct me if I'm wrong, but all of these policies with respect to NQTLs apply to their entire book of business, right?
That's a really great question. My thought and I would like to get back to the committee to verify, but my thought is that what they would provide to us is a self-analysis of the plans that we regulate. However, we are the primary enforcers of the PR. So let me, if I could get back to you on that.
Yeah, that would be great. Thank you.
Thanks. Based on our the preliminary responses, what we found with respect to prior auths, concurrent reviews, and medical policies, since they all sort of involve the same NQTL analysis, is that for the most part, there is consistent application across all benefit classifications, in that if there's for instance, a prior auth required for non-emergency inpatient care for medical surgical, then there will be the same thing for mental health and substance use disorder. We have also found that all three insurers utilize clinical committees to determine coverage criteria and do utilization management. And there's comparable methodology for determining the services that will be subject to utilization management. So that's all good. That's sort of what we want to see in terms of how the issuers themselves are thinking about NQTLs for prior auth. So now let's talk about provider reimbursement, because this is where this analysis kind of gets complicated. So the methodology and process for negotiating in-network provider reimbursement is comparable between mental health and substance use disorder services and med-surg services. So if you're a mental health provider, your process for going an in-network contract with MVP is going to be identical to if you were a primary care provider. Where things are different is in terms of the codes that different providers can bill. And in our sort of initial look at this is what we're finding is causing reimbursement differences between mental health providers and med-surg providers, even when they are providing basically the same service. So just to give all of you an example, you might have heard the term E&M codes in your work here, which are evaluation and management codes. They're basically codes that providers use to bill office visits. And they tend to reimburse more than other codes used for the same or similar services, which is great if you are a PCP. But if you're, say, a licensed social worker or any other master's level provider, you cannot bill an E&M code. And that's in the coding rules. So it's not necessarily a NQTL that's being imposed by the issuers. It's a limitation on what they can bill, and so they're getting reimbursed less for office visits just for that reason alone.
So who creates the coding rules?
Yeah, the coding guidance is developed by the American Medical Association.
That's interesting. So the coding work you're talking about in the beginning is not this, or it's not fixing this?
No, what we were talking about in the beginning was with respect to fixing any kind of limitations on like prior authorization that would appear in their forms. There is some of it for reimbursement that we might be able to address, but this is why the coding issues are particularly tricky, just because with things like the E&M codes and who can use them are largely out of the department's control, and also really into the weeds of how medical billing works. Yes.
I don't know if in your role you have gotten into this, but have you seen creative workflows sort of address that hurdle?
It's something that we're going to look into over the summer, and it's something that we're looking forward to discussing with the stakeholders.
Yeah.
I'm just thinking, are you thinking about requiring, say, E&M codes to be covered by, to be able to be used by, or are you more thinking of taking the equivalent mental health provider codes that they would use and ensuring that the reimbursements are equivalent to E&Ms? Is that,
I think we're,
what was your thought process here?
I think we're thinking of anything that we can do to address like this particular issue with at a very broad level. The problem that we're looking at in the mental health reimbursement space is that mental health providers have tend to have lower credentials than med-surg providers who have like MDs or nursing degrees or like other credentials that let them bill more complex and thus higher reimbursing codes. So yeah, I think we're going to be thinking about all of those options in terms of trying to address this.
Yeah, and if I could add, I think what we're trying to do here is point out some inherent what might seem like things that are not in parity, but have some, kind of obscure source and may be justified. And what I also would like to just say is this type of analysis that we're talking about is required by the companies. It's a new relatively form of like self-analysis that they have to perform and then justify to us. So a lot of it is way, way behind the scenes for them, looking at processes as opposed to us being able to suss these things out in their contracts. And the other thing is that some of the negotiations of provider rates and provider contracts are confidential between the insurer and the provider.
To the point you just said, I was wondering if you all were looking at, if you're a mental health substance use disorder provider, you're less likely to be affiliated with a large facility and you have zero negotiating power. And I'm wondering if you're looking at, the rates and maybe perhaps the state negotiating.
That is
a powerless social worker.
That is another good question, and unfortunately, it's an issue that is not unique to mental health. I mean, I think you could talk to any independent physical therapist in the state, and they would tell you that the same thing. But that is definitely a component here in terms of the reimbursement differential between mental health providers and physical health providers, just in that more mental health providers are independent.
Okay.
Leslie?
I'm just interested in the quotes oversupply, because we've been hearing.
I was going to talk about that.
Okay, great.
So another thing that's happening in terms of reimbursement is that, again, going back to credentialing levels, insurers want to incentivize participation in insurance networks by psychiatrists, especially. So they get reimbursed more for providing certain services. And it comes at the expense of all of the master's level providers. It's very similar to what happens on the med-surg side in terms of insurers trying to incentivize participation by PCPs.
Primary care providers.
Yes.
There are psychiatric nurse practitioners, and I don't know about PAs, but for sure. So where would they fit in this? They're probably masters prepared, but.
Yeah.
But they prescribe. So I'm just thinking about this distinction between the ability to prescribe or not.
Yeah. So our sense of the situation is that the higher up you are on the credentialing chain, psychiatrists, the licensed psychiatric nurses, the less of a reimbursement differential there is. And the reason that we see a big reimbursement differential overall is just because there are so many master's level providers in the mental health space.
Yeah. Glad that we're looking at this, because just yesterday we had some celebrations that so much of our work is going to be trying to go into communities with other types of providers. So appreciate that you're looking.
Yeah, and this is a fundamental question, I guess, and I'm trying to follow all of this, and so it might be kind of off base here a little bit. Does the law require a dollar for dollar likeness or a percentage likeness when it talks about provider reimbursement?
Yeah, so neither federal law or state law requires a dollar for dollar parity analysis between med-surg providers and mental health providers. And even on the med-surg side, there is a differential between, say, what an MD is reimbursed and what a nurse practitioner is reimbursed, even if they are billing the same code. So what the law requires is just that the methodology for reimbursement be the same between the two sides of the coin. But to Representative McFawn's point, I think this is among the reasons that there's been a push to just say that like mental health care is healthcare. Yeah. And then then you're sort of out of all of these issues of like, well, what is a licensed clinical social worker equivalent to on the med-surg side?
Would you be able to track it though if you did it that way? I mean, would you be able to ensure compliance if you just made it one? Probably, I guess. But.
I think it would be easier to ensure that providers with similar levels of credentials got reimbursed equally for providing a given service. Yeah.
Gotcha. Thank you.
I think, compliance is obviously the first thing that we want to look at, but also covering the true cost for delivering care. And I don't know if that's why, reimbursement is a theme that I keep coming back to, and sustainability for providers, especially mental health providers this session. I wonder if there's any opportunity to provide technical assistance to providers around accuracy in billing for E&M codes. For example, when psychiatrists are billing E&M codes, do they really need to provide the full 45 minutes to bill for the session? Or technically, can they provide 15 minutes and still bill for the 45-minute code? Which I think in many cases is true, or in some cases is true. That's just one example of where I think some small providers can be, compliant, but not necessarily covering the true cost to deliver care.
Right.
And so I wonder if there are opportunities to provide technical assistance to make sure that we're both meeting compliance and also making sure that our providers are, sustaining those services and also keeping up with the change that has happened in the E&M billing processes.
Yeah, I think this is something that independent providers on both the mental health and med-surg side could speak to. But in general, one of the big advantages that hospitals and hospital systems have, big provider groups, is that they have billing departments that they have like full-time staff members that all they do is try and maximize revenue that can be billed. And so I think you should talk to independent providers about that, but I think there's certainly an opportunity.
And if I could just chime in, Sebastian, to add that while provider reimbursement is certainly very complex, that from a consumer perspective, we do have dollar for dollar, caps, and making sure that exactly if you have a $20 copay for your PCP, you got to have a $20 copay to see your mental health provider for an office visit. So just wanted to clarify that our law does require dollar for dollar when it comes to what the consumer pays.
Last question, and then I do want to make sure you get
It's not a
through
question. It's not a question. I just would really like to say maximize revenue by appropriately billing for services that are provided. I want to add that in there.
Yes, that's a great point. And when you have a staff that's supporting you in doing that, it's a lot easier.
Yeah, I'll say yeah.
So we have two more slides to get through, and just really quickly want to touch on provider accreditation, which is an issue that we've already noted in the context of residential mental health care. And this is actually an issue because provider enrollment and credentialing criteria apply to all providers. And there are certain contexts where, especially in the mental health space, it's very difficult to gain admission to insurer networks. So this is part of the work that the department's going to do over the summer to try and make it easier for those, for instance, residential mental health providers to go in network with health insurers because they could just rely on DCF licensure instead of trying to get outside accreditation, which can be time consuming and costly. Another thing I wanted to note is that yesterday we had a great meeting of the Mental Health Integration Council, and a lot of the discussion focused around peer supports. And this is another kind of service where the issue of provider accreditation makes it very difficult to kind of fold into how insurers bill for services. So I think as more services like peer supports and mobile crisis units come online, this will be an even more urgent question of how do we either kind of wrap them into the current billing system, or otherwise make sure that there's a mechanism to reimburse those providers for their services.
Is there an equivalent in the med-surg world?
Have you ever had your friend fix your broken knee?
Yeah.
Thank you, Anna, for articulating what I was trying to struggle.
So I'm sorry, that sounded facetious or not. I just want to understand a little more what you mean.
No, I literally mean it's a really difficult, mental health parity is wonderful, but it has some drawbacks. And one of them is this precise thing, is that there is no, that I can think of, and I think about this stuff in the shower and all day long and all night long in my dreams. So I have yet to think of a situation that's equivalent, and I invite any, feedback.
What about
a way to, and there's no equivalent peer support that I can think of, where the peers receive reimbursement, like peer support in some like a heart care program, care management after a heart disease. Sometimes they do have kind of groups where people can recover together. But it's facilitated by a group leader, right? It's the people who are providing that kind of peer feedback and group about how do we eat better and move better. Those peers are receiving services, they're not receiving reimbursement. So I can't think of a similar, so that's where I think mental health parity with all of its strengths may fall short, because I can't think of a way to get those peer supports on the hook using mental health parity. There's other ways. We're looking at other ways.
So there wouldn't be a doula. I don't think there's reimbursements for doulas at this point yet.
That's correct. In my there's midwife coverage required, but not doula coverage required. People mostly pay out of pocket for that.
Pepper.
I was just going to say that as we get into the peer support therapy, let's call it, I see between alcoholism, drug abuse, mental health, I do see connections with peer, trying to think of the word, services maybe, that are being provided. And, I personally think that they ought to have codes where they can be reimbursed. We're moving towards that. And some of that work is exceptional.
Yeah.
Totally agree.
Yeah.
So I think Brian is on Zoom and had a question if he's still there.
Yeah, I'm still here. I had a
Great.
question. I had a question earlier, so it's going back a little bit, but I'm wondering when the rules were made that about master's level clinicians due to oversupply, because my experience over the most of my career has been that there's not enough of us for all the people who want help. So I'm just curious, and then I also wanted to confirm that I heard that it was the medical society who decided this. I don't know if that's what I heard earlier.
The American Medical Association, which is the national Doctors Lobby
Yeah.
is the group that publishes the CPT code book and current procedural terminology. It's the book that defines all of the codes and when they can be used. And we can follow up with the issuers about how long they've had policies in place with respect to trying to incentivize participation by certain providers based on perceived oversupply or undersupply.
Thank you. And I'm curious what if you could find out when they what their cycle of revision is, because I know for example, and I don't know if everyone's going to know what this is. The DSM is a manual of that creates the codes for diagnosing, and it gets revised every certain amount of time. And then it changes, the coding we use for diagnoses, and some things that are once a diagnosis no longer are a diagnosis, or new diagnoses are created. So I'm curious in terms of these codes, what the cycle is for revision, too, if you could find that out.
Yeah.
And if I could add, because I know we're running out of time really fast. I can't help but think if the codes are designed by doctors, then they're going to be protectors of doctors' territory, and wondering what that access, and that's sort of associated with Brian's question, what is the access for other providers? And I don't know, imagine you know that, but it's a worry of mine.
Yes, I think that's something that I think about too, just in terms of we have a healthcare system that, for instance, treats dental care as a completely separate thing.
Right.
Just like mental health care was once considered a completely separate thing. So yes, that's a concern.
All right, let's get to our next slide.
Okay, so
Make sure we finish.
last slide, and this is about restrictions on billing codes. So this has less to do with the reimbursement level that a given provider can bill based on their credentials, and more to do with the specific services that are being billed. And lots of insurers have claims edits in their claims processing systems. And these are basically rules that might cause a provider to become ineligible for payment based upon what they billed. They apply to all provider types, but there are certain edits, usually having to do with bundling or unbundling, which are just requirements that services have to be billed together, that can disproportionately impact mental health providers. So this is an example, but an insurer might require mental health providers that are providing medication-assisted treatment to bill code G2068, which includes all of these services, instead of billing out each of those services individually, where they might get higher reimbursement for billing out those services individually. So that's an issue that in theory would apply to, it's a claims edit that in theory would apply to all providers, but in practice would disproportionately impact mental health providers. So that's one more thing that we're looking at as part of this mental health parity analysis.
So when will you have a final, are you doing a report? Are you doing would you come back for a presentation?
Yeah, I'd love to come back for a presentation and to talk about what we found and what we've done. So we're anticipating that the work will be finished by early next year. So I think that the timing would work out great for us to come back to you next session.
Great, wonderful.
If I could just chime in about expectations.
Yeah.
This is absolutely the beginning of this work. And the first batch of work is collecting the self-analysis performed by the companies. And then, sorry, I get a little distracted by my own face.
We all do.
So, we're really looking at self-reported information, a great deal of it, and trying to sift things up to the top. And I would say that I really hope that with another round of CMS grant funding, there's been a lot of talk about how states are the primary enforcers of MHPAEA, but we received no funding to expand our processes. And so we're hoping to have another round of funding to support this work. And it would be my suggestion that some of that be used by our market conduct team, where we have the ability to go deeper with the company, go through their procedures, look at the claims. It's done under a confidential procedure in our statutes. So I do just want to say that any kind of report is probably going to be a report of our findings of the first round of self-analysis performed by these companies. And so we're surfacing issues, very excited about it, and we really do want to tackle them. But I think that the tackling is not going to be the finished product at the end of this year. And I also just wanted to note that I do appreciate that, treating mental health and med surge in parity, like we can do a lot better with our language. I do want to point out that for my work of trying to hold these carriers accountable, the differentiation between mental health and med surge and now the new tools of MHPAEA are going to they actually give us the tools to dig deeper. And so that distinction is actually important to us in this work. And we're not, we're doing this kind of digging independent of, consumers and stuff. So I support the language changes and just want to say, like, the distinction does give us tools and we really want to use them. Thanks.
Great. Thank you so much, everyone. I really appreciate your time. Really, really fast, because I want to finish up something with the committee to say goodbye.
The bundling that you talked about, is that also related to what some larger national companies or multinational companies have done around bundling, like with dialysis, or unbundling and fraudulently bundling or unbundling?
No, it does not.